David Carr, Dr. Carr. Do you remember this, the stage?
I do, but
Yeah.
I think this lazy thing is kind of offensive.
To?
Me, I'm lazy.
Oh no, come
You
on.
got lazy.
Okay, here comes lazy.
I remember this stage, and I want to say it's fantastic to be home. Next year will be my 15th year speaking at EMU. And I have no doubt that this conference is single-handedly responsible for paving an opportunity for people to speak and having a platform. This is the preeminent conference in Canada. Thank you for coming. As much as I like EMU, I like syncope more. I've always loved syncope. I just decided that in 2022 I was going to start talking about it. 1% to 3% of our visits are for syncope. In our lifetime, 48% of the time, we will faint. This will happen to you or me. Will you be ready? But what this talk is not about is a biomarker. And what I'm going to even try to tell you further is that the electrocardiogram is gravy. What is relevant here is something much bigger. Now, some orders of business here, some conflicts of interest. I routinely lie about fundoscopy and JVP. I'm just like you. My POCUS skills are okay. And during COVID, I barely examined patients in the first wave. But what my gift is I can take a story. I can take a history. And cardiology is an EKG. It's a biomarker, and it's a history. But what I want to tell you today is that history is queen. That history is everything. And I want to give you 20 years of pearls on taking a history of patients with syncope. Now, for those of you who are on Twitter, Amal Mattu puts on this whiteboard teaching. He does night shifts. I hate night shifts. He's the only person who I actually want to work a night shift with. And this was on one of his whiteboard night shift teachings in 2014 and stuck with me. And Amal coined this rule of 15. 15% of syncope is cardiac, and 15% of these sinister non-cardiac conditions will syncopize. Look at this list. This is EMU. You are not going to miss the hypoxic, the chest pain, the pregnant, all these tearing pain things. That's not here. What we're going to focus on is the 15% of cardiac syncope, and knowing that up to 30% of elderly people who syncopize will be in fact cardiac. So let me give you some pearls. Probably the most important study happened 4 years ago in Annals. 3,600 elderly patients, and they compared them into groups of 1,400 of near syncope and 2,200 of syncope. And they followed them for 30 days. And what they found is it makes no difference if you faint or you almost faint. We have been blowing off, well, I didn't faint. She didn't faint, who cares? It's the same shit, right? You have to treat these people equally because they have the same major adverse cardiac events at a month. You have to realize that if you almost fainted or fainted, it's the same. Stop blowing off the near syncopes. If you face plant, if you chip your teeth, if you break your glasses, when you go down, you should be nervous. I want to tell you a story. I saw a young 26-year-old teacher many years ago, and she started off the interaction with, "I'm so sorry, Dr. Carr, to be wasting your time. I should be at the dentist." And in that moment, just like you, I knew something bad's going to happen, right? These apologetic, sweet people always have bad crap going on. So I already didn't like her story. So she said to me, I'm a teacher, I'm low maintenance, my showers are 5 minutes, I get up at 7:45, I'm out at 7:50, I'm on the road at 8:10, I'm in school by 9. Today I woke up face down at 8:30 in my shower, missing my 2 front teeth. I'm sorry, I should be at the dentist. Oh, your teeth? Yeah, I get the teeth part, but I don't like your story. You've apologized, and your story was concerning. So what did I do? I consulted medicine. Do any of you work with internists? Some of you? Well, what do you think they did? They sent her home. Dave, we did 2 troponins. We were going to do a 3rd. They're all normal. We sent her home. I said, well, I don't like her story. I don't care about her troponin. Well, they sent her home, and I got some feedback from one of my colleagues. And Carolyn said to me, you know that person you saw? It always starts bad, right? I was really worried about her. I heard your note. I read your note. I believed in her story. I did a Holter, it was normal, and I put in a loop, and she had torsades. And you know what the best part about this is, Dave? She has a twin sister, and they now both have defibrillators. If you want to save lives, you better learn how to take a story. Respect people who go down without warning. Respect people who don't have pre-syncope. When you're about to syncopize and you go like this, that's bad. Whereas if you're like, oh, it's EMU, it's been a few years, and I'm kind of nervous this bright lunch. There's more people than I expected. I actually feel like I need to sit. That's nothing. Warning is everything. Establish pre-syncope and feel better than you do. But when you don't have time to pre-syncopize and you chip your teeth, be afraid. You guys know this person? Pheidippides, the fastest runner in Athens 2,500 years ago. Well, Pheidippides was involved in a situation where the Turks were invading the Greeks. He was in a city called in a city called Marathon, which was 26.2 miles away from Athens. As the Turks were invading, he ran as fast as he could to tell the emperor that the Turks were invading, and then he died without warning. I'm sure if he had teeth, they were chipped. Exertional syncope should always make you nervous. Now, this is the first incident of sudden cardiac death in sport, but there are countless. Be worried about exertional syncope. Now, with bystanders, they always give you this mixed up report. Was it a seizure? Was it a syncope? I'm always stuck with this. I always don't know what to do. I'm going to make this simple. If you have epilepsy and you're not sure, you probably have epilepsy. You probably seized, right? If you're postdictal, yeah, that's probably a seizure. If you have tongue biting, but remember, if you have lateral tongue biting over here, it is 96% specific for a seizure. Remember, people who syncopize, they drop their tone, but people who seize are tight. Prodrome and incontinence mean nothing. But if you don't want a busy slide and you want something simple, you should know the rule of 10 and 20. Anyone know the 10-20 rule? I love this rule. If we know that 90% of people who syncopize have myoclonic jerks. A few of them, right? If you watch incidents of Christopher Erickson, Hank Gathers, they all dropped. They all had a few beats before they had their cardiac arrest. If you have less than 10, that's syncope. If you have greater than 20, that's a seizure. The 10 to 20 rule is a wonderful rule, especially when you're challenging bystanders to recollect the story. How many of you routinely ask patients who syncopize if they have a family history of sudden cardiac death? Keep your hands up. Keep your hands up if you've hit. I've hit once, but it's rare that someone says, funny you ask, I lost my 14-year-old sister. That doesn't happen much. What I want you to also pivot is realize that if someone had an incident or a family event where someone in their family was involved in a single unprovoked motor vehicle collision, if someone drowned in their family, These are missed opportunities to diagnose cardiac death. The family won't recognize that if someone drowns, they'll think it's a horrible, horrible tragedy, which it is, but it's a missed opportunity to elicit further detail and workup of sudden cardiac death. Think about exploring your family history of sudden cardiac death to ask about driving and drowning. Paramedics. 10 years ago, I got a frantic call from a caregiver saying that my grandmother had fainted while brushing her teeth. I was worried about Bubs. She was going to a hospital that wasn't mine. And I spoke to the paramedics, and she told me that her heart rate was 30 and she needs to go to this hospital stat. I get to the hospital. I was so happy because I was met by one of my old trainees. And she approached me and said, "Wonderful. Grandma looks great. Blood work looks great. EKG looks great." I didn't recognize my grandmother because she wasn't wearing dentures, and she was mortified that I saw them without them. And they were going to send her home, and I said, "Hold on. I heard her heart rate was 30. Do you have the strip?" "No." "Can I see the strip?" "Well, we don't have it." "Do you have, are the paramedics, are they still here?" "Well, we can check." Oh, this is the crew that brought Miss Feldman here. "Do you have a strip on her by chance?" "Yeah." The strip showed her heart rate was 30. She was in complete heart block. She needed a pacemaker. And we had her for 10 more years. The strip is the holy grail. Never let medics leave without a great strip. And in fact, when I see AFib in a patient, when I see something weird, sometimes I'll take the patient's phone and take a shot of it and say, "Show this to your family doctor. Show this to your neurologist. Show this to the cardiologist, because this is life. This is everything. Take that photo," because I was worried that that strip wouldn't make it into the chart. You know, it's funny. Whenever I prepare for a talk, I always get handed a gift. Do you guys ever get that way? Like I'm giving a syncope talk in EMU and this strolls my way. This is a person who came in with crushing chest pain right into recess, had a terrible ECG, kind of that non-occlusive, an occlusive MI picture, but a non-STEMI. The story was crushing chest pain. We lost her for about 10 seconds on way, but she came back. She's all good now. I said, "You lost her? What was that bit?" "Can I see, you have a strip of that?" "I don't know." "Do you have a monitor?" "Yeah." "Can we go back to the monitor?" "Yeah." "This is my picture." She had VTAC. It's not just aspirin, Tycag, and heparin and medicine consults in the morning. This is a code STEMI. This person had a VT arrest. Look at the strip. Don't let them leave without it. People with pacemakers don't have vasovagal syncope. I'm going to say that again. People with pacemakers don't have vasovagal syncope. The reason they have a pacemaker is because their heart sucks. They need to have their pacemakers interrogated when they faint. That may be annoying for you. That may take extra work, but assume that they have a heart problem when they faint. It requires the extra steps. Some of you don't examine patients anymore. What I'm going to tell you for those who don't, that this is an ultrasound for your ears. Put your stethoscope on people who faint. It is embarrassing if you see someone who faints and you don't auscultate that murmur of aortic stenosis. Go back to basics, and please promise me you listen to the heart of everyone who syncopizes. Go back to first principles. So there's your physical exam. What about this? You're not making a brilliant diagnosis on blood work. The workup of syncope is an EKG, a good history, a physical, an auscultation, maybe a beta HCG in the right person. I'm not talking about the person who's had her period for a month and is bleeding and obviously needs a CBC. But in the minor story, it's not always about lab work. It's about the basics. Can we take that history, that physical, that lack of blood work, and put it into a rule? Whether you believe in the San Francisco syncope rules if you're an American, whether you believe in the Canadian syncopal score if you're a Canadian, they both need more validation. They both don't outperform Gestalt. If you take an excellent history, You can diagnose syncope without a rule that you'll never memorize. Don't rely on decision rules. Take a wonderful history. And remember, the workup and conclusion of syncope is going to, in often many cases, be done outside of your shop. But if you think someone is not safe to drive, you must notify the Ministry of Transportation. It's not seizure that's the only indication for people to have their license reviewed. If you think someone has cardiac syncope on history, they should not be driving, and I feel very strongly about that. Okay, I can't in the last 10 minutes not ignore that you aren't going to listen to me talk about histories without showing you some ECGs. But can you imagine the audacity of the marketing director of McDonald's to advocate for the Big Mac diet and show a strip of some kind of P waves that go wonky in a non-sustained run of VTAC? Like someone needs to lose their job, right? Those golden arches don't look too healthy, right? Let's show ECGs. Again, this is EMU. I'm not showing you and teaching you about blocks. But if someone's heart rate's 36, they probably have something wrong with their heart, okay? I'm not talking about like super fit people. You know who those people are. Getting a bit self-conscious now. But an 80-year-old diabetic doesn't have a normal heart rate of 30, so they need to come in. Let's talk about real ECGs that aren't obvious. But I'm not talking about ECGs without telling you a story. I grew up idolizing Hank Gathers. I grew up liking Reggie Lewis. Both of these basketball stars are no longer with us. Both of these basketball stars died on the basketball court. Both of these stars syncopized in the weeks before their death and returned to play. If Gathers or Lewis saw you in the emerge, you would have taken their history and learnt about exertional syncope. And you wouldn't have even needed their ECG because you would have been nervous. But if you saw their ECG, you would have looked at it. You would have looked at it and said, they have LVH. Remember, you don't have LVH unless you have an inciting stimulus like chronic hypertension or aortic stenosis. You know, we kind of just say it's LVH, but the cardiologists care about why they have LVH. 25-year-olds shouldn't have LVH because they're not people with chronic diseases. You might look at them and say, they've had an old STEMI, there's some Q waves. If you look at this ECG, you see dagger-like Q waves in the inferior lateral leads in 2, 3 AVF and V5, V6. But pathological Q waves are 3 boxes. These are dagger-like Q waves that they sharp, they poke, they kill. These are not STEMI Q waves. But the story in Gathers and Lewis is they dunked and they dropped. You don't need the ECG. It's gravy. Had you seen them, would you save their lives? This young couple came to see me. They were German tourists. They were at Center Island. It certainly isn't in the photo. And they saw an ice cream truck. They pedaled really fast. The young woman got off the truck and went down. Do you need to see her ECG? You're done. She went exertion, drop, done. But she hands you something. And I'm going to tell you that I rarely read the box, but for syncope I do. And I look at the rate, but I kind of can tell by looking. And I look at the PR interval, and I know it's normally about 0.12. I look at the QT, I look at those things, and I said, she's got a short PR. That computer's right. Now, you hunt for delta. You hunt for it because you already know that she's given you a gift. And you can see how beautiful her delta waves are exhibited in lead 2 and AVL. But her story is everything. This is a gift. The story is everything. This happened to me about 15 years PC. Sorry, 15 years before pre-COVID, yeah. 15 years pre-COVID, this happened to me. I saw this person, he had a fever, right? Like everyone who has a fever now is COVID, so we have to be careful about that. So he has a fever and palpitations and felt like he was going to faint. I get asked to see his ECG stat and come see him because on the ECG, the nurse has done two things. She's put my name on it, and she's also wrote acute STEMI, or someone, that computer person who's quite bright wrote acute STEMI. His story didn't sound like a STEMI. He was 26. He didn't have COVID because it was PC. But he had down-sloping ST elevation in lead V1 and V2. I had been waiting for this my whole life. This was my first Brugada. Do you remember your first Brugada? How good did that feel? I was like jacked for weeks about this. I told everyone about it. I showed everyone. I want to tell you two things about Brugada. One, when you have a fever, you get profoundly arrhythmogenic when you have Brugada. So often this will bring it out. These people who are survivors of Brugada need to be taking paracetamol or Tylenol or whatever you want to keep their temperature down to suppress the arrhythmia. Number two, if you miss Brugada, there's a 10% chance that this person's dead in a year. If you miss Brugada tonight, there's a 10% chance that this person's not alive for EMU in 2023. Don't miss Brugada. That fever and palpitations might throw you as a benign, maybe he's just taking Tylenol cold. Look for that. Any of you rock climb? I know you said you're not lazy. Are you a rock climber, Richard?
A rock climber.
Okay, so I don't rock climb, but this person did. She's a paramedic and she's out with her partner and she gets to the top of this incredible peak. It's an indoor gym. And she rings the bell and then she drops. And correct me if I'm wrong, she gets blade? Yeah, she gets blade down and her partner, she feels her pulse, notices it to be fast, freaks out like all of us would be, and then she eventually comes to. Does anyone like her story? She's coming in. Someone else needs to be involved. And she gives you something. She gives you something. You look at her ECG, and she gives you something called ARVC, arrhythmogenic right ventricular cardiomyopathy. How do you know that? This is a once in a career. Epsilon waves, excellent. So what I want to tell you is that in WPW, right, we have a delta wave where it's like really hard to get to the top, takes a long time. In ARVC, you get up, you get down, but to go from the nadir to the isoelectric baseline is obtuse. It's blunted. And buried in that wave is that little blip called an epsilon wave. I like to think of this as a reverse delta because you go up, you go down, but you can't make it back. The other thing is you see T-wave inversion of V1, V2, V3. But her story was everything. You just need to memorize one more thing. Any of you see old people who fall and keep coming to your emerge and get CT heads every week? Recurrent, frequent flyers? Oh, damn them, right? This woman had been in our emerge 4 times in a year. She's had 4 CT heads. Everyone gets a CT head when they fall and they're old. Her ECG looked the same every time she was there. Every time she was there, it said on the top, bifascicular block. You know, in the old days, we would have called this a trifascicular block, which is a bifascicular plus a first-degree AV block. Now, the cardiologists, they don't really like it. They don't respect it. It's not really heart block. It's just a bi with a first, okay? I don't care what it is. If you have 3 fascicles and if you have a bi, assume your third got screwed when you syncopized. Syncope plus a bifascicular block. Syncope plus a bifascicular plus a first-degree block needs telemetry and someone else to decide they need a pacemaker. Up to 30% of elderly people who syncopize are cardiac. And remember, when you have 2 fascicles down, it wouldn't be shocking if the third, which is hanging on by a string, screwed you over, right? Don't keep CTing heads of elderly people falling. Use your head and make a diagnosis. These are your gifts. If you get this, what I would say on every syncopal patient, You'll look for HCM. You'll look for WPW. You'll look for ARVC. You look for Brugada. You look for long QT. Just document it's none of those on every one of your charts, and I promise you, you won't miss it. If you have grandparents, if they've moved away to the cottage, if you're getting up on years, a defibrillator is kind of like the fire extinguisher of the 21st century. You need one of those, right? These are going to save your lives if your parents or grandparents have moved to remote areas during COVID. You know that red fire extinguisher you have in your kitchen from 1986? That defibrillator probably needs to replace it. That's my public service message. What can I tell you? History is queen. History is everything. You establish pre-syncope. You ask about exertional stuff. You don't work up these patients. You take a story. The ECGs are gravy, and they're a gift. Thank you so much for coming. We'll see you next year.
Dave. Do we have some questions for Dave? No? Yes?
Yeah, there's one question for Dave.
Dave, you want to answer a question, maybe? You know when I ask people about sudden death in the family, when they're demanding antibiotics for me, and then I pretend to write one for macrolide, and just before I hand it to them, they say, oh, before I give it, is there any sudden death in your family? And they go, you know what, I don't want that antibiotic.
That's great. The pearls you learn at EMU.
This is EMU pearls.
Question.
So thank you, Dr. Carr, for your talk. You mentioned at the beginning, speaking to a consultant, you referred the patient based on your history, no prodrome, and they were sent home. How do you deal with it now? Because I think we've all been in that situation where, young, healthy people without prodrome have been sent home. We're bed blocked these days. So how do you deal with that consult now?
So this is a whole podcast in itself. What I would say, and the question was, how do you deal with patients who get sent home? In most cases, you're not even there when they get sent home. I think the most important thing that you have to realize is that when faced with difficult discussions is that it's not about you, it's not about the specialist, it's about the patient. You advocate. Sometimes we need to advocate, and that decision might not be what we would do, but that's their decision. Like at the end of the day is, if they want to arrange something and they can get a Holter and telly and stuff in the next morning, that's fine. But all I need to do is say, look, I'm extremely worried. I don't want to send this person home. I'd like you to consult. What they choose to do, unfortunately, a lot of times, if it's a staff who's accountable, what can we really do? I wouldn't fight it, and I just didn't even know, right? I mean, they rely on things like troponins, which is always the big joke. She's 26. This is not a manifestation of ischemic heart disease. This is a bad story. So I think you are faced with challenges. I think that's one of the hardest parts of our job. All we need to do is just don't take it personally. This is what I think, and I'm happy for you to give an opinion once you see the patient. If you're comfortable to send them home, that sounds great. But I'm not.
Okay. Well, what percentage of people have a heart attack, faint, get better on their own, come in and feeling totally fine afterwards anyways?
It's a good point. It's a good question.
Yeah,
You'd have to poll the audience.
Yeah. Thanks, Dave. Okay, thank you, David.